Hi everyone, this is Abby, PGY2 Oncology Pharmacy Resident, and today I'm going to be discussing the new medication Relugolix, also known by the brand name ORGOVYX. Objectives for the presentation include discussing Relugolix, as well as the important caveats and pearls associated with this new medication, and then evaluating primary literature that gained Relugolix's FDA approval. Relugolix is a non-peptide gonadotropin-releasing hormone antagonist, and it does this by competitively binding to the pituitary gonadotropin-releasing hormone receptors. Ultimately, it blocks the receptor and then also decreases secretion of luteinizing hormone and follicle-stimulating hormone. Through this action, it results in decreased testosterone levels in the patient. Now looking at the FDA-approved indications for Relugolix, this is currently approved for prostate cancer in the advanced setting. Gonadotropin-releasing hormone receptor agonists or antagonist therapies are generally continued upon development of metastatic or non-metastatic castration-resistant disease, so this will apply to Relugolix as well. Here I have listed all of the current FDA-approved therapies for agents that work on the gonadotropin-releasing hormone system, either through agonism or antagonism. As you can see on the farthermost right column, the antagonist, Relugolix, is the first of its kind, being that it is a tablet available in the oral dosage form, and this was FDA approved on December 18, 2020. For Relugolix, castrate testosterone levels, so less than 50 nanograms per deciliter, were observed by day 4 in over half of the patients within the clinical trials. Also, throughout the treatment period of 48 weeks, almost all of the patients maintained castrate levels through that time period. Relugolix is protein-bound, approximately 68 to 71%, primarily to albumin. It does go through metabolism, primarily hepatically, via the CYP system, 12% approximately for bioavailability, and it does have a mean effective half-life of 25 hours. When looking at the excretion, 81% is excreted in the feces, and approximately 4% is excreted in the urine. When dosing Relugolix initially, it does have a loading dose of 360 milligrams on day 1, or 3 tablets, followed by 1 tablet, or 120 milligrams, once daily thereafter. For missed doses, if the dose is missed by greater than 12 hours, it's recommended not to double up on doses and just to resume with the next scheduled dose. However, if therapy is interrupted for greater than 7 days, it's recommended to reinitiate therapy with that initial loading dose of 360 milligrams and then drop down to 120 milligrams once daily thereafter. Looking at the dosing for any hepatic or renal impairment, this has not been studied. However, there were no clinically meaningful differences in the kinetics that were observed with mild to severe renal impairment or in mild to moderate hepatic impairment. So this is likely going to depend upon a case-by-case basis. Relugolix is administered orally at approximately the same time each day, given with or without food. The warnings and precautions associated with Relugolix are relatively similar to that of other androgen deprivation therapy, being that this may prolong the QT or the QTC interval. When considering the initiation of Relugolix, it's important to consider the risk versus benefit of ADT in patients with congenital long QT syndrome, heart failure, frequent electrolyte abnormalities, and then concomitant use of medications that are known to prolong the QT interval. Along these same lines of warnings and precautions, it's important to look at any disease-related concerns, with cardiovascular disease being important, as androgen deprivation therapy may increase the risk for cardiovascular disease. As well as diabetic patients, androgen deprivation therapy may be associated with an increased risk for insulin resistance and then also diabetes. The most common adverse effect that was seen with Relugolix in the clinical trials was hot flash at 54%. Other endocrine and metabolic adverse effects that were noted was an increase in the blood glucose as well as an increase in the triglycerides. Interestingly, Relugolix caused the same amount of constipation as well as diarrhea, both at 12%. This will be interesting to see how this plays out in the clinical picture to see if patients do experience one or the other more frequently. Other side effects that were noted were hematologic issues, specifically a decrease in the hemoglobin, as well as some potential for an increase in ALT and AST, fatigue, and then finally musculoskeletal pain was noted at 30%. Relugolix is available in the 120 milligram strength tablet, and this has an average wholesale price of $92.52 per tablet. So being that it is a new agent, it is rather expensive. The other interesting thing to note is that it only comes in a package size of 30 tablets. Therefore, this is what the treatment plan has been built with. For patients who are initially starting, they will have that first dose of 3 tablets, and then they'll have 27 tablets left to finish. So that first prescription will actually be for a 28-day supply versus a 30-day supply. However, once they're back on their normal schedule and they're not having to do the loading dose, this will work out for an even 30-day supply for the remaining months. Being that Relugolix is rather expensive, there are some other outlets available for patients to help with financial assistance and copay support. This is an example of a coupon or copay card that I was able to find at the ORGOVYX.com website, and this has patients who do have commercial insurance being able to pay as little as $10 per month. Coupon cards are only valid for patients who do have commercial insurance. Therefore, this excludes those patients who have a federally funded insurance, such as Medicare. However, for these patients, there should be some other options that we could look at, such as grant funding or other types of patient support programs that we could potentially look into to help with this costly copay. The trial that gained Relugolix's FDA approval was published in 2020 in the New England Journal of Medicine, and this is the HERO trial. This is entitled Oral Relugolix for Androgen Deprivation Therapy in Advanced Prostate Cancer. As previously mentioned, Relugolix was developed as an oral agent that is highly selective, and it acts as a gonadotropin-releasing hormone antagonist that inhibits pituitary release of luteinizing hormone and follicle-stimulating hormone. Interestingly, the agonists, such as Leuprolide, which is a commonly used medication, do not actually fully suppress FSH. This has been thought to be a potential mitogenic growth factor for prostate cancer cells. This was a multinational, randomized, open-label phase 3 trial that assigned patients in a 2-to-1 ratio to receive oral Relugolix 120 milligrams once daily after the approved loading dose, or Leuprolide 22.5 milligrams every 3 months for 48 weeks. Patients with major adverse cardiovascular events within 6 months prior to this trial initiation were excluded. The primary endpoint of this trial was a sustained castration rate, and this was defined as the cumulative probability of testosterone suppression to less than 50 nanograms per deciliter during the trial treatment from day 29 through 48 weeks. Looking at the key secondary endpoints, this was non-inferiority of Relugolix to Leuprolide with respect to the sustained castration rate with a non-inferiority margin of negative 10 percentage points. If non-inferiority was demonstrated, then the trial was analyzed for superiority, cumulative probability of testosterone suppression to less than 50 nanograms per deciliter on day 4 and day 15, and then finally looking at percentage points of patients with a PSA response of greater than 50% decrease at day 15 with a confirmation at day 29. From April 2017 through October of 2018, a total of 622 patients received Relugolix and 308 patients received Leuprolide. The mean PSA level at baseline was higher in the Relugolix group at 104.2 nanograms per milliliter than in the Leuprolide group, which was 68.6. Sustained testosterone suppression below castrate levels from day 29 through 48 weeks was achieved in 96.7% of the patients in the Relugolix group and in 88.8% of the patients in the Leuprolide group. Sustained castration in the Relugolix group was determined to be non-inferior to that in the Leuprolide group, with a between-group difference of 7.9 percentage points. In terms of the key secondary efficacy endpoints, looking at the Relugolix group versus the Leuprolide group, all of the key secondary endpoints did favor Relugolix as being statistically significant in their difference, all with a p-value of less than 0.001. Safety between Relugolix and Leuprolide was relatively similar between groups, with a higher percentage, for the most part, of adverse events actually occurring in the Leuprolide group. One of the adverse events that authors really noted within the trial was the incidence or percentage of major adverse cardiac events, abbreviated MACE. Looking at Relugolix, any grade for a MACE was 2.9%, versus any grade in the Leuprolide group was 6.2%. Therefore, authors concluded that Relugolix was associated with a 54% lower risk of acquiring a MACE than that of being on Leuprolide. Even though a lot of the adverse effects did occur at a higher percentage in the Leuprolide group, there were some that were higher in the Relugolix group, specifically hot flashes and diarrhea. The most common adverse event in both groups was hot flash. However, again, this was just a bit higher in the Relugolix group at 54% versus 51% in the Leuprolide group. Diarrhea occurred in 12% of the Relugolix group and in only 6% of the Leuprolide group. Authors concluded from this trial that Relugolix achieved a rapid, sustained suppression of testosterone levels that was superior to that of Leuprolide. They also discussed that there was a lower risk associated with a major adverse cardiovascular event for patients who were on Relugolix as compared to Leuprolide. There was also some mention of adherence, being that Relugolix is an oral tablet that patients take at home. Treatment adherence with oral Relugolix in this trial was more than 99% and similar to that of injectable Leuprolide. This is a clip from an article that I had sent to me from the Journal of Hematology, Oncology, Pharmacy, and it really talks about the excitement and the buzz around this new oral medication, and also that it really is a timely approval, as this can limit the patient's exposure to clinic during the coronavirus pandemic, and may be beneficial for patients who do feel more comfortable being treated in their homes at this time. The NCCN guidelines have recognized Relugolix with their newest update in the prostate cancer guidelines and have it listed as a treatment option for an LHRH antagonist. Also, I did want to make mention that the guidelines do recognize that Relugolix has not been adequately studied in combination with other androgen receptor inhibitors such as enzalutamide, apalutamide, darolutamide, or abiraterone, nor has it been studied in combination with chemotherapy, so docetaxel or cabazitaxel. There's also some potential for other off-label uses of Relugolix. There was a recent article that was published in New England Journal of Medicine that utilized Relugolix in combination with estradiol and norepinephrine for the treatment of uterine fibroids. Authors concluded that this once-daily combination with Relugolix resulted in a significant reduction in menstrual bleeding as compared to placebo, and it also preserved bone mineral density in women with uterine fibroids. Again, this is currently not an FDA-approved indication, but potentially something that could be used off-label, or potentially something that will be approved in the future for labeled use. In conclusion of today's presentation, Relugolix is a novel therapy, being that it is in the oral dosage form, and it does provide a new treatment entity for patients with prostate cancer, who originally had to receive types of therapies such as these through the subcutaneous or the intramuscular route. And finally, I did want to mention again the cost, as some of these copays may be rather high. However, through the use of the coupon cards and different funding, hopefully we are able to get these copays to something reasonable for our patients where they are able to use Relugolix. Thank you for watching this presentation. If you have any questions, you can always email me at aferdinand@monument.health. Thank you.